Hello, this is Bonnie An Henderson, and welcome to the AAO 2020 Industry Showcase. It's a pleasure to be partnering with FCI Ophthalmics, and I'd like to speak today about the Henderson Capsular Tension Ring, which is made by Morcher. I have no financial interest. Capsular tension rings, otherwise known as CTRs, have been an important innovation in ophthalmology. They were introduced in the early 1990s, and since then, surgeons around the world have utilized capsular tension rings to stabilize a capsular bag during cataract surgery. The original conventional CTRs, as you can see a picture on the slide, are these open-ended flexible loops made of PMMA, and the idea was once they were placed inside the capsular bag, it placed centrifugal forces against the capsular equator that supported the area of zonular weakness by recruiting tension from existing zonules for redistribution over the areas of zonular lysis. Since the original conventional ring was invented, there have been several modifications over the years. Bob Cioni has invented the Cioni ring, which has been a great invention by allowing these eyelets to be placed so that we can suture the capsule tension ring onto the sclera. Ahmed also created the segment ring with a similar idea with eyelets to suture to the sclera. However, there are smaller segments instead of having the complete 360 capsular tension ring. One of the challenges in using a CTR is the difficulty of removing nuclear or cortical material once the ring has been implanted. The circular ring compresses any residual lenticular or cortical material against the capsular bag and impedes its removal. To combat this difficulty, I created a modification called the Henderson Capsular Tension Ring Type 10C. This ring has 8 equally spaced indentations of 0.15 millimeters. It is still made of PMMA and has the same centrifugal force parameters as the Morcher Type 14 conventional CTR, and the spring forces are constant. The inner compressed diameter is 11 millimeters and the expanded diameter is 12.29 millimeters. Here's a diagram of the modified Type 10C CTR made by Morcher. It was FDA approved in 2009 and is distributed by FCI Ophthalmics. Inflate the capsular bag fully with a cohesive OVD. The modified CTR comes preloaded and ready to use. Slowly inject the CTR aiming towards the area of zonular weakness so the pressure from the leading eyelet is relaxing the zonules in the weakened area. As a trailing eyelet is being injected, point the tip of the inserter posteriorly, allowing the trailing eyelet to insert into the capsular bag rather than releasing anteriorly in the sulcus or above the iris. The timing of the implantation of the CTR depends a lot on the clinical case. So most people will recommend to implant the CTR as late as possible in the surgery, but as early as necessary. So this may mean placing the CTR before phaco emulsification in certain conditions, or in some cases, it's to place it after the lens has been removed and before the implantation of the intraocular lens. However, as I described in the previous slides, the timing of the conventional CTR is difficult because once a CTR is placed, it does compress the residual lenticular and cortical material against the capsular bag. However, with this modification, the timing is more liberal since the modification allows those indented areas not to compress the residual cortical material as much as the non-modified models of the CTR, and therefore the surgeon does not have to worry as much by using the modified CTR about having difficulty removing the cortical material. Although the original purpose for the modification of the Type 10C HCTR was to allow for easier removal of the residual lenticular cortical material after implantation of the CTR, there has been a lot of anecdotal evidence that this modification also decreases the rotation of the toric intraocular lens. This is found to be true especially in the eyes that are at high risk of toric rotation, such as eyes with long axial lengths, megalocornea, and traumatic cataracts. After the capsular bag has been inflated with a cohesive OVD, the modified CTR is carefully inserted into the capsular bag anterior to the IOL. I recommend injecting the CTR counterclockwise to minimize the chance of catching the optic-haptic junction of the IOL with the leading eyelid. If the trailing eyelid did not inject into the capsular bag with the initial insertion, use a Y hook or a similar instrument to dunk it posteriorly into the capsular bag. Because of this anecdotal evidence that the modified CTR was useful for inhibiting the rotation of a toric intraocular lens, we decided to create a new modification of the modified CTR. This was really initiated by John Zedral, and the new ring is called the Zedral Henderson Type 20C ring, also made by Morcher. This newest modification, the Type 20C ring, is similar to the Type 10C ring, except it has additional indentations. So there are 17 indentations in a sinusoidal pattern. It is the modified C shape and made with PMMA, and the size of the indentation is similar to the ends of the haptics of the toric intraocular lenses. To investigate the efficacy of this newly modified Type 20C CTR in inhibiting the rotation of a toric IOL, a prospective experimental study was performed. The study was performed at the Moran Eye Center at the University of Utah by Doctors Liliana Werner, Nick Mamalis, Sneha Bantu, and Sean Kennedy. The results of this experiment was drafted into a manuscript, and the manuscript has been accepted for publication in the Journal of Cataract and Refractive Surgery. In this study, the cadaver eyes were prepared in the Miyake apple technique, and the eyes were filled. The eyes were implanted with toric intraocular lenses. Both the Acrosoft and the Tecnis toric IOLs were used. And in the eyes, the toric IOLs were attempted to be rotated in the clockwise and counterclockwise directions. They were studied in 3 conditions. Number 1, with a toric IOL implanted alone. Number 2, a toric IOL with a standard conventional CTR. And number 3, the toric IOL with a modified ZH-CTR Type 20C. The attempted rotations were evaluated by 4 different observers, and the results showed that the ZH-CTR statistically improved rotational stability of both types of toric intraocular lenses. Because of the findings of this study, this newly modified ZH-CTR Type 20C has been submitted for FDA approval by Morcher. We hope that with approval, this new ZH-CTR will improve stability in all eyes implanted with toric intraocular lenses. I want to thank you for listening to this presentation, as well as to FCI Ophthalmics and Morcher. And I also want to credit the co-inventor of the ZH-CTR, Dr. John Zedral. Thank you, and I hope you have a wonderful AAO meeting.
Hello, I'm Cathleen McCabe, and I would like to share with you my experience using the Morcher EyeJet CTRs. The general indication for using a CTR is missing or damaged zonules, and this often results in lens subluxation. It can be present in the case of pseudoexfoliation or high myopia with a long axial length and a floppy capsular bag. You can have zonulolysis, or in cases where there is a risk of excessive fibrosis, such as retinitis pigmentosa. And we can divide these into either primary zonular weakness, such as in the case of Marfan syndrome, or even secondary zonular weakness, where the cause is trauma, either preoperatively or intraoperatively, or maybe from prior surgery, such as a vitrectomy. Some of the advantages of using a CTR is that it allows for circular expansion of the capsular bag by distributing the stresses on the capsular bag and on the zonules evenly, so that the stronger or more intact zonules can support the areas of the bag where there are either weak or missing zonules. It allows for a stable condition during surgery, And it may be that putting in the CTR earlier allows for safer removal of the cataract. It improves IOL centration in cases where there is localized weakness of the zonules and decentration of the capsular bag and therefore the IOL. It reduces the risk of capsular fibrosis, and again, in cases where the patient is younger or may have a history of intraocular inflammation, or cases like retinitis pigmentosa or other cases where you know that the risk is greater for phimosis and fibrosis postoperatively. It helps to resist capsular shrinkage in these cases, and it can be inserted through a very small sub 2.2 millimeter incision. Some unique features for the EyeJet Type 15 CTR are that the leading edge has a very gentle curvature, a gentle elbow, and this provides a broad area of contact and allows it to glide more easily against the equator as you're advancing the CTR into the capsular bag. This reduces the risk of snagging by the leading end or puncturing of the capsular bag in areas where there's weakness and maybe a fold develops just anterior to the leading edge of the CTR. The EyeJet Type 15 CTRs are available in 3 different diameters to accommodate individual patient needs, determined by looking at the size of the eye and anticipating the size of the capsular bag. They are designed to stabilize the capsular bag, and they're preloaded on a disposable injector, the EyeJet, which makes it very easy to open and then insert the CTR. Some of the advantages of the Type 15 CTR again are additional safety that help reduce the risk of puncturing or bulging the capsular bag at areas of weakness or areas where the capsular bag is not well supported and becomes floppy and redundant and sometimes develops folds. This can also lead to entrapment of the leading edge of the CTR and then can result in a posterior capsular tear, sometimes out in the equator where it's difficult to recognize at first. And so you may actually be inserting the CTR through a tear and behind the capsular bag or behind the additional zonules without even realizing it. And it can introduce iatrogenic zonular damage if you're pulling on the capsule in an area where there's a fold that's entrapping the leading edge of the CTR during insertion. So these are preloaded CTRs. They do come in a right, which is a clockwise implantation, and they will support up to 4 clock hours or 120 degrees of zonular damage. And they are made out of a clear PMMA material. So here's what they look like. And the Type 15 is for an axial length less than 24 millimeters. The Type 15A is for 24 to 28 millimeters, and that tends to be the type that I have and put in. And then for the highly myopic eyes, it's the Type 15B. And really, I feel like you can put in even these larger sizes, and what happens is the ends just overlap, and at least it's always large enough for whatever eyes you're addressing. And I'd like to share with you an actual case where this design of the Type 15 preloaded CTR was especially helpful. This video demonstrates a modification of the Morcher Capsular Tension Ring, where the leading end of the capsular tension ring has a little bit more acute curvature so that when it's introduced into the capsular bag, there is less stress on the zonules and a smoother introduction. So this is a case with a small pupil with posterior synechia, and you can see I have broken the posterior synechia with a dispersive viscoelastic, and now I'm using 2 Kuglins to stretch the pupil. I would not do this maneuver if it were a case of IFIS, as that would make the iris even floppier during the surgery. That was not the case here though, and additional viscoelastic was introduced to expand the pupil. The Capsulorhexis was then performed with Utratas. And during the capsulorhexis is usually when you get the first idea that there's some instability of the zonules or weakness of the zonules in one area or even generally. And because of this instability, I made the decision to introduce a capsular tension ring. And you can see when it came out, it just has a little bit more acute curvature at the tip of the CTR. And that allows for a smoother introduction with less distortion of the bag and less stress on the zonules at the opposite side from where the leading edge or leading end of the CTR is being introduced. And then an intraocular lens was implanted. So here's a second case. Again, appreciate that little bit more acute angulation or curvature of the leading end of the CTR as it's being introduced. This is the preloaded EyeJet version of the CTR, and I prefer this because it's very fast and simple to introduce it at the time that you notice the need for it during surgery. Nothing special has to be done to load an inserter with the CTR. Now here's a case of a very loose bag, and even during the irrigation aspiration, it was very apparent that there was poor zonular stability that was generalized. And because the bag is so loose, it's often jumping into the irrigation aspiration port, and so care has to be taken not to engage and cause further weakness of the zonules. Once the capsular bag is inflated with viscoelastic, a traditional type 14 Morcher CTR was attempted to be introduced, and there was significant displacement of the capsular bag. You can see how much straighter that introductory end of the CTR was. I even tried to manually create a bigger curvature by just kind of forcing a bend in the end. And there are other techniques that can be used, such as putting a suture through the end or a Sinskey hook. But in this case, I chose to just try to create a more acute angle at the leading end of the CTR. And it was still distorting the orientation of the capsular bag and dragging in the fornix. I then switched to the new type 15 design of the Morcher CTR, and you can see that just that little bit of an increase in the acute angle of the curvature at the end allowed it to be inserted without displacing the capsular bag significantly. Even though I did have to hesitate a little bit here, drew it back and then inserted it, and it went around very smoothly and allowed for less trauma to the remaining zonules during insertion of the CTR. So there are several things to learn from the previous cases. With the EyeJet Type 15 preloaded CTR, it's important, as with any CTR, to deliver it in the direction of maximal weakness of the zonules. So you can see I was pointing the CTR in most cases to the area where I was most concerned. Of course, if there is diffuse weakness of the zonules, then you'll just pick a direction. But you want to not be pulling on the already weakened side by putting the original traction in the opposite direction. The leading curve of the Type 15 modification does help guide the CTR as it moves forward within the capsular bag and helps to avoid entrapment in the loose equatorial bag, especially in cases such as the last one shown in the video. You want to advance slowly and watch for rotation of the capsular bag in the direction in which you are advancing the CTR. You want to watch for folding of the capsular edge, or especially an S-shaped deformity of the CTR as it comes out of the inserter, indicating that forward motion along the equator of the bag has been interrupted. You should stop if any of the above is noted, or if there is an increase in resistance to the advancement of the CTR in the bag. Retract the CTR and try to either reposition or slowly advance again. Sometimes it makes sense to actually add additional OVD and inflate the bag. and that will remove some of the peripheral laxity and the potential for a fold to develop. So it's really the increased curvature of the leading end of the CTR that helps prevent any further trauma to the zonules or the capsular bag. So this does really help, having that original curvature. And even in cases where you're using the type 15 modification, I just wanted to show this technique as well. That if, despite all of that, you're still finding that there's a little bit too much stress on the zonules, having a second instrument such as a Sinskey hook or a quick chop, which is what I think this one is, and putting that through the leading eyelet is still possible, even with the 15 modification. So that, you have two sort of different levels of intervention to decrease any stress on weakened zonules. You can use the type 15 modification so that it slides more easily into the capsular bag. And then if you're still concerned that there's more loose zonules or a risk of entrapment, you can use a second instrument through the eyelet, such as demonstrated here. And both of those mechanisms together help to reliably insert a CTR in a very atraumatic way. And this is just one more case demonstrating that the curvature on the CTR when there's a type 15 modification is really helpful. And thank you for your attention.
Hello everyone, good morning. I'm Dr. Fuxiang Zhang, ophthalmologist at Henry Ford Health System, Michigan, United States. I'm going to briefly discuss the difference between type 14 and the type 15 capsular tension ring. Both are from Morcher, Germany. There's no financial interest to disclosure. Capsular tension ring has special functions and indications. Generally speaking, it can be used in weak or missing zonules. The bag is not round shape anymore in those situations. And the ring can enforce symmetry on the bag, round out the oval shape of the capsule bag, and evenly distribute the holding force. It also reduces the tendency of toric implant to rotate towards the narrowest position. The older version was type 14, which we used for quite a few years and worked very well. It has three different sizes: type 14, type 14C, and the type 14A. The problem of the type 14 was the leading eyelet of the ring. It's pretty good, but it was not good enough. It still has a risk of snagging or puncturing the capsule bag. Dr. Tim Page, ophthalmologist at Bowman Hospital in Michigan, published a great paper in 2015 GCRS. He introduced a suture technique to make the insertion safer. A tangle nylon suture was passed through the leading eyelet of the ring, which make the insertion much smoother and greatly decrease the risk of snagging or puncturing the capsule bag. Of course, we know with extra step of suture, it is time-consuming and inconvenient. So in 2018, Morcher made a great modification. They introduced type 15, which also has three different sizes: type 15, 15A, and 15B, based on different axial lengths. Well, what's the major difference between the two types? On the left is the old type 14. On the right is the new type 15, which has a much gentle leading elbow. That will make the insertion much easier, safer, with no need to pass a suture. Sometimes the leading elbow can be visible during the insertion. As in this case, this is toric implant I did a few months ago, as pointed by the red arrow in this picture. Here is the video as the same case as the previous slide. As you can see, the leading elbow is visible during the whole process of insertion, which certainly makes the surgeon much more comfortable. Conclusion: new preloaded Type 15 CTR is safer and easier to use. The prominent leading gentle elbow is a significant improvement compared with the previous Type 14. The risk of snagging or puncturing the capsule bag is extremely low. Thank you everyone for your attention and have a great day.